Hello, my name is Lynn Gilbert. I'm an infectious diseases physician and have worked for many years at Westmead Hospital. In this talk, I will describe how antibiotics are used and sometimes misused in community medical practice, and some of the ways that have been suggested to improve their use in order to reduce the problem of antibiotic resistance. The advent of antibiotics in the 1940s has been described as one of the most important advances in medical history. Starting with penicillin in the 1940s, many different classes of safe, effective drugs were developed that cured most serious bacterial infections without significant adverse effects and dramatically reduced the rates of premature death from infection, at least in those countries where medical care was accessible. Because of antibiotics, cancer chemotherapy, organ transplantation, and many types of major surgery became feasible and relatively safe, even though they necessarily involve an increased risk of infection because of immune suppression or temporary damage to physical defences. All of this led to tremendous optimism, even complacency, in the latter half of the 20th century, and a belief that infectious diseases would soon be a thing of the past. But there was a downside. As pathogenic bacteria have been exposed to antibiotics repeatedly, most have developed resistance to one class of antibiotic after another, and successful treatment of bacterial infections can no longer be taken for granted. And of course, antibiotics were not the only factor responsible for falling death rates from infection during the 20th century. Improved sanitation, housing and availability of clean drinking water, better nutrition, vermin control and vaccines all made major and arguably more significant impacts on the incidence and hence mortality from infection. Nevertheless, the optimism of the past has rapidly decreased in the last decades to the point where some experts are predicting the end of the antibiotic era. Many bacterial infections are more difficult and expensive to treat because they're resistant to many commonly used drugs. While this is most apparent in hospital practice, there are many community-acquired infections such as TB, pneumonia and gonorrhea, among others, which now often fail conventional treatment. Moreover, the large pharmaceutical companies have turned their efforts away from antibiotics to more lucrative drugs, and virtually no new antibiotic classes have been developed since the 1970s. All of this has prompted belated concern among the general public and consequently politicians who until recently have been unwilling to accept the warnings of doctors and scientists about the implications of antimicrobial resistance, including, for example, an estimated $55 billion annual direct and indirect cost in the United States due to antimicrobial resistance, and an estimated 50,000 deaths per annum in Europe and North America, and 700,000 globally due to antimicrobial resistance. The World Health Organization has declared that antimicrobial resistance is a threat to global security. A recent UK Government Commission review predicted that unless a solution is found soon, the death rate due to antimicrobial resistance will increase from the current estimated 700,000 per annum worldwide to 10,000 million per annum, more than that of cancer and other major causes of death combined. This dire situation has resulted from ongoing, excessive, often inappropriate medical use of antibiotics in rich countries, including Australia, where medical care is affordable and many doctors regard antibiotics as harmless, even if not strictly necessary or effective for some types of infection for which they are prescribed. In developing countries, many people have no access to affordable medical treatment or prescribed antibiotic therapy, even for serious bacterial infections. But cheap and often ineffective drugs are available over the counter without regulation. Overcrowding, poor personal hygiene and inadequate hospital infection control all increase the spread of multi-resistant organisms from person to person. In many countries, antibiotics have been used widely as growth promotants in food-producing animals, and vets are just as likely as human doctors to prescribe antibiotics inappropriately for treatment of individual animals or prevention of infection in whole herds or flocks, thus increasing the risk of spread of antibiotic resistance from animals to humans. Careless disposal of antibiotics from factories, hospitals and individual homes contaminates the environment and increases antibiotic resistance among environmental bacteria to which animals and humans are exposed. There's a strong correlation between the total amount of antibiotic used and the incidence of antibiotic resistance in the same communities or environments. Some of the ways that antibiotics are used inappropriately in human medicine are common to all settings in which they are prescribed. For example, they may be prescribed unnecessarily for viral infections or trivial self-limiting infections. An ineffective or unnecessarily broad-spectrum antibiotic may be chosen. It may be given in the wrong dose, by the wrong route, or for longer than necessary. All of these inappropriate uses increase selection pressure on bacteria to develop resistance, whether they're significant pathogens or the normal bacterial inhabitants of the gut, which are essential for health. In general practice, it's estimated that 30 to 60% of prescriptions are for acute upper respiratory tract infections, most commonly the common cold, although they make no difference to the severity or duration of symptoms. A review of 120,000 prescriptions in 568 general practices in the United Kingdom showed that 30 to 80% of GPs prescribed an antibiotic for these common upper respiratory tract infections and rarely recommended that patients wait to have their prescriptions filled to see whether symptoms would improve spontaneously. Some factors that contribute to inappropriate prescribing in general practice are obvious. When a patient first presents with a suspected infection, the diagnosis is often uncertain. Even when it seems to be a simple viral infection, an occasional patient, say one with underlying risk factors, which may or may not be obvious, might be incubating something more serious or will deteriorate in the next few days. What the doctor decides is driven not only by the patient's condition, but also by her past experience, tolerance of risk, and concern about the time and cost involved in confirming the diagnosis or delaying treatment, as well as the cost to her reputation should she make a mistake. And some patients expect or demand a prescription because their symptoms are more severe or have been present for longer than usual. We all feel fed up towards the end of a bad cold. This makes the doctor's dilemma more difficult, especially when the waiting room is full of similar patients, and it will take several times longer to explain why an antibiotic is not needed than to write a prescription. There are some different factors at play in antibiotic prescribing in residential aged care facilities. Elderly people are more susceptible to infection because of reduced immune competence and physical frailty, and so are frequently given antibiotics. They're often admitted to hospital for various reasons, so generally have higher rates of colonisation and infection with multi-resistant organisms. If they share accommodation with other susceptible elderly people, pathogens are more likely to spread, especially if some residents are incontinent and unable to look after themselves. These risks are increased by frequent courses of or prolonged antibiotic therapy, whether or not it's appropriate. And it often is inappropriate because many staff in residential aged care facilities have limited training and expertise, and they must relate to many different GPs who provide care to residents. Drug orders are often given over the phone on the basis of inadequate information and without proper instructions about the dose and duration of treatment. A recent survey of medical records in residential aged care facilities in Victoria showed that at the time of the review, less than 5% of residents had signs or symptoms of infection. However, more than twice that proportion were being given prescribed antibiotics. No reason for the antibiotic treatment was recorded for at least a third of prescriptions, and the duration of treatment was not specified in 2/3. Many residents had been receiving antibiotics continuously for 6 months or more, without review. There's another important factor that contributes to inappropriate prescribing. Doctors are appropriately and understandably focused on the patient in front of them, and they need to make a quick decision. Even if they're aware of the risks of antimicrobial resistance and the possibility that their prescribing decision could contribute to it, any adverse effects will be, in the future, uncertain and unpredictable, as expressed in this quote from a recent paper which explored doctors' motivations behind antibiotic prescribing. The rules of the game are heavily weighted in favour of the management of immediate clinical risks, reputation, and concordance with peer practice vis-à-vis longer-term population consequences. It's acknowledged that effective and possibly drastic measures are now needed if we are to avoid returning to the pre-antibiotic era, where some people suggest we're headed. The problem is how to do this so as not to deprive people of the benefits of antibiotics when they need them, and encourage both prescribers and the public to cooperate in such a way as to achieve the goals rather than to resist in a way that defeats them. A number of measures listed here have been suggested, including better education of both prescribers and the public about the risks of antimicrobial resistance and what they personally can do to reduce them, increasing the price of antibiotics to reduce demand, asking patients to share responsibility for their treatment by waiting to have a prescription filled in the expectation that symptoms will resolve on their own, developing ways to make prescribers publicly responsible for prescribing decisions, and finally, increasing regulation of antibiotic use. Let's look at each of these options in turn. Obviously, prescribers need to know how to prescribe antibiotics appropriately and the risks of not doing so. And if we expect patients to cooperate with doctors' prescribing decisions, misconceptions about antibiotics need to be addressed. There's no shortage of antibiotic prescribing guidelines, educational opportunities for prescribers to keep up to date with latest developments, and easily acceptable sources of information for the public. But there's a catch. The target audience may not listen. They may listen but not change their prejudices, or they may change their opinions but not their behaviour. Most educational campaigns have at best modest and very short-term effects. However, we have a lot to learn from commercial advertising agencies who have devised successful approaches to marketing which, though often expensive, are worth the cost to the client if they change consumer behaviour. Social marketing techniques have been used in health promotion and other health-related areas in a limited way, but could be used much more widely and effectively. They're based on several simple but important rules that conventional educational approaches often ignore. Make the message clear and simple. Define the behaviour you want to change. Understand your audience or audiences so that the message is appropriately targeted to each. Emphasise the personal benefits of behaviour change. Any benefits to others are a bonus but not the primary motivation. Then promote an attractive, memorable package that will motivate change. Taxes or other methods of increasing prices can reduce the use of a product. They reduced cigarette consumption, for example, and during its brief lifespan, the carbon tax reduced greenhouse gas production. The argument for increasing the price of antibiotics is similar to those in favour of a cigarette or carbon tax. The current relatively low price does not take into account the social, health and economic costs of their adverse effects. The price of antibiotics should more accurately reflect all of these costs. Revenue from a tax or surcharge on antibiotics could be used for research, developing new antibiotics, or compensating people who suffered from antibiotic-resistant infections, and it would provide a strong disincentive for patients to demand unnecessary prescriptions. However, there are two important arguments against the increasing the cost of antibiotics. To be effective, the increased cost would have to be borne by the patient. At present, most of the cost is paid by government via the Pharmaceutical Benefits Scheme, and antibiotics are generally very cheap for the patient. Socially and economically advantaged patients often regard doctors merely as service providers rather than expert professionals, and so are more likely to make demands. Any increase in the price of an antibiotic is unlikely to deter them. Relatively disadvantaged patients are generally less likely to demand an unnecessary prescription, but they may be unwilling or unable to afford the extra cost of an antibiotic prescription when it's needed for a serious bacterial infection. So in general, this solution would be inequitable and could have serious health consequences for the less well-off in the community, and is unlikely to be effective unless very carefully targeted. A study in low and middle-income countries showed that in countries where consumers were faced with greater out-of-pocket expenses, the rates of antimicrobial resistance were higher. The reason for this was assumed to be that cost-sharing in the public system drove demand to the private system, where the quality and use of antibiotics is difficult, if not impossible, to regulate. As we've seen, acute viral respiratory infections rarely progress or develop into something serious, but nevertheless many people consult their GP. They may hope for or expect a prescription, but often would be happy with reassurance, especially if given a prescription as a safety net, to be filled in a day or two if their symptoms don't resolve. This is a sensible and effective way to reduce unnecessary antibiotic use. However, it means that the patient needs to share responsibility for his care. Whether it will work depends on the doctor's clinical judgment, his willingness to take the time to explain, and the patient's trust. It would be difficult to enforce or regulate except in well-defined situations, because it depends on individual circumstances and personalities, and must ensure that treatment is not delayed when an antibiotic is needed immediately. A number of trials have shown that encouraging doctors to justify their prescribing behaviour to their patients or peers will reduce inappropriate prescribing. In essence, this means that they need to acknowledge the potential risks of unnecessary antibiotic use for both the patient and society, and judge their own decisions objectively. The first of these two studies in the United States showed that when family doctors displayed a signed poster with their photograph in the examination room pledging to avoid inappropriate antibiotic prescribing, the proportion who prescribed an antibiotic for an acute respiratory tract infection fell by 20% compared with the control group of doctors. The second study compared three different interventions. In the first, a pop-up screen in the electronic health record, to which the patient had access, prompted the doctor to give a justification for any antibiotic prescription. In the second, data from electronic health records were used to compare individual GPs' prescribing patterns with those of their peers and report back to them where they ranked in a league table of appropriate prescribing behaviour. And finally, a pop-up screen appeared in the electronic health record when an antibiotic was prescribed for an acute respiratory infection, indicating that an antibiotic was not in fact indicated for this condition, and providing a list of alternative therapies. The first two of these three interventions, which required the GP to be publicly accountable for his prescribing behaviour, resulted in significant reductions in prescribing for acute respiratory tract infections compared with control groups. Whether these results would translate to the everyday reality of a busy routine practice over time would depend very much on how the interventions were implemented. Again, the techniques of social marketing could well be the key to success. Finally, many people believe that education, pledges and appeals to reason and common sense, however well-meaning, will never change entrenched behaviours. Instead, the only way to make people change is to regulate behaviour and punish those who fail to comply. This approach has worked in a number of situations. Enforcing road rules, mandatory seatbelts in cars and helmets for cyclists, smoking bans in public places and bans on cigarette advertising have all significantly reduced the consequences of dangerous behaviours and have generally been accepted by the public without major protest. Surely regulating the use of antibiotics has at least as much justification. There are already restrictions on prescribing of some of the last resort antibiotics in general practice, but the benefit of this is limited if other antibiotics are substituted. And, as we've seen in a research setting, public accountability should reduce inappropriate prescribing, but it would need to be effectively monitored and enforced to ensure compliance. In my view, carefully increased regulation of antibiotic use would be justified and effective so long as it is carefully regulated and targeted and sensitively implemented. So, in summary, there's good evidence that conventional didactic education alone is not effective in changing behaviour. There are significant ethical, social, political and medical risks involved in increasing the cost of antibiotics, but a well-constructed long-term program of public and professional communication using well-established social marketing techniques, appropriate data collection and feedback to prescribers with appropriate privacy safeguards could change antibiotic prescribing behaviour for the better. For such a system to be effective, it's likely to be expensive and politically difficult, but certainly not impossible to implement. But the cost would be offset by long-term public health, social and economic benefits on a smaller scale than, but of comparable benefit and complexity to programs designed to mitigate climate change. Thank you for your attention.